Hello everyone. So today we will be discussing about the antepartum hemorrhage and Rh negative pregnancy. You all know that Rh negative is less important topic as far as FMG is concerned, and antepartum hemorrhage is very important topic. So usually we get one or two questions from this topic. So let's start it. Okay. So again it will be a TND session. Okay. So first of all, this is the question which has come in AIMS May 20. A hypertensive pregnant female, it presents with abdominal pain, vaginal bleeding and loss of fetal movement. What is its diagnosis? Okay, so we should know the symptoms of placenta previa and abruption placenta to differentiate. First of all, here there is vaginal bleeding, okay, and here there is pain also, so it means it is a painful bleeding plus there is loss of fetal movement, so there is a fetal distress also. So this is a triad which is specifically seen in abruption placenta. Let's rule out the other causes. Preterm labor. In preterm labor there is no bleeding and there is no loss of fetal movement, okay. In placenta previa the bleeding is painless, okay, and in hydromenose there is no bleeding and no loss of fetal movement, okay. So the all these three things are seen in only and only in abruptio. Let's see it. Antepartum hemorrhage. What does antepartum hemorrhage means? Antepartum hemorrhage means that the bleeding is from the genital tract. Please note the point that bleeding is from the genital tract. It is a genital bleeding. It's not a nasal bleeding. It's not any other bleeding. Okay, it is from the genital tract. Okay, and it is after the fetal age of viability. Okay, it is after the fetus has become viable. Okay, so in India the viability of the fetus is 28 weeks. So if bleeding from genital tract it occurs after 28 weeks, then it is the antepartum hemorrhage. I hope now you understood. Now there are three reasons of antepartum hemorrhage, mainly three reasons. There can be other reasons too: abruption, placenta previa, and vasa previa. Out of all this, abruption is much more common than placenta previa, and the most rare is vasa previa. Okay, now what is basically abruption? Abruption is premature separation of placenta. We all know that placenta separates after the delivery of the fetus, but if the placenta separates from the uterus prematurely, then that is known as antepartum hemorrhage. Okay, now what are the risk factors that prone a patient to कि उसका प्लेसेंटा जल्दी सेपरेट करे? ठीक है, नंबर वन एंड द मोस्ट इम्पॉर्टेंट इज प्रीवियस हिस्ट्री ऑफ एब्रप्शन. ओके, काफ़ी टाइम हो गया, रिस्क फैक्टर्स पे क्वेश्चंस नहीं आ रहे हैं, बट दे कैन कम. डोंट फॉरगेट टू लर्न देम. डोंट जस्ट यू हैव टू मेक अ कंसेप्ट. इफ देयर इज अ प्रीवियस हिस्ट्री ऑफ एब्रप्शन, then in the next pregnancy abruption can occur. Now placenta is separating. For example, this is uterus and this is placenta. This is uterus wall and this is placenta. Now placenta is separating, so it will be only when this uterus is over distended. Okay, over distended, so it will separate the placenta. So over distended uterus is seen in multigravida, it is seen in twins, it is seen in polyhydramnios. So what all are the causes of PPH? In PPH we learn in what all we will see the over distended uterus in macrosomia. So when this uterus is over distended, so placenta can separate, right? And the another cause is trauma. The more other causes are infection and elderly and multigravida, or any problem is there in the blood, that if there is increased coagulation, then also internally the placenta can separate. Okay. Okay, now it is there that risk factor, you have studied that most important is previous history of abruption. The second most important risk factor is the over distended uterus, and the third risk factors are some problem in the blood which leads to the separation of the placenta. It can be hypertension, it can be thrombophilia. The another causes infection. Along with it, there can be cocaine use or folic acid deficiency. Okay, so once again I will revise with you all the risk factors. Number one risk factor is previous history. The another risk factor which we have to calculate and which you have to see in primary gravida, they are any distended uterus condition. Then in number one is this distended uterus. Number two is any blood disorder. Hypertension is the most important risk factor which the examiner keeps on giving in the exam. Okay, the hypertension or thrombophilia, and number three is infection. Four is folic acid deficiency or cocaine abuse. Okay, now this antepartum hemorrhage is of two types: concealed or revealed. Concealed means that separation was occurring but no bleeding is, that separation occurred like this centrally. This is uterus and centrally, so no bleeding come and no bleeding came outside, then it is known as concealed abruption. Reveal means that the bleeding came outside. Okay, so they can be of two type: concealed and revealed. Concealed means the bleeding, the separation has occurred but the bleeding is in behind the placenta, and it is inside the uterus but it is not coming out of the vagina. So it is a concealed abruption placenta, and revealed is that the bleeding is coming outside the vagina, it is revealed. Okay. Okay, now this is a question from FMG December 2019. It says 32 years old lady with pregnancy, mild bleeding and pain. Again with bleeding there is pain. On examination uterus is tender and fetal heart rate is absent. What is the diagnosis? So again the same triad: painful, bleeding and fetal distress. So it is known as, it will be seen in abruption placenta. Many questions have come. Now this is a patient at 37 weeks presented with bleeding per vaginum in labor and tense tender abdomen. Again painful bleeding. Her BP is 150 by 100. Hypertension. I told you examiner keep on asking this risk factor again and again. Cervical dilatation is 5 centimeter and full effacement. Fetal heart rate is 144 with beat to beat variability. The diagnosis is, now this time there is no fetal distress but there is 2 points are present: painful antepartum hemorrhage. It is abruptio placenta. Okay. Pregnant woman brought to the emergency room with pain, abdomen and hypotension. Now this time the lady didn't have a hypertension, the lady had hypotension. On examination there was abdominal tenderness, fetal heart rate was not felt. So along with the pain abdomen there is abdominal tenderness. Again it is telling us that some problem is tenderness. Uterine tender is a feature of abruptio placenta, and fetal heart rate was not felt. Again fetal distress. So it is again here Hypotension is there because all the bleeding is of the concealed variety. सारी bleeding अंदर ही हुए जा रही है और patient को hypotension हो रही है, bleeding अंदर ही अंदर हुए जा रही है. So this is a case of abruption. Okay. Next is cochlear uterus is seen in, yes, cochlear uterus is seen in abruption placenta. We will discuss what is cochlear uterus. The term cochlear uterus is used in relation to uteroplacental apoplexy. What is apoplexy? Apoplexy means एक तरह से extreme गुस्सा नहीं होता, उसको बोलते हैं यूट्रस और प्लेसेंटा के बीच में जब एक्सट्रीम गुस्सा हो जाता है तो उसको बोलते हैं कॉवलियर यूट्रस. अभी मैं आपको बाकी सारा बढ़ाती हूँ. सी हियर नाउ व्हाट इज द ट्रायड. एज आई टोल्ड यू दैट इन APH there is separation of placenta from the uterus. Now when there is separation, the arteries they open. Let me show you. See, this is uterus. Okay, here spiral arteries are there, and this is placenta. Now when this placenta separates, for example, this placenta separated from here. Now what will happen? These spiral arteries they will bleed, and yes, these were spiral arteries of which were supplying the placenta. So now these spiral arteries they will bleed, and blood will accumulate behind the placenta, right? So blood will accumulate. For example, this blood will accumulate behind the placenta, and now this blood will go into the myometrium like this. Okay, now you know when blood goes into the myometrium, it causes lots and lot of pain. That is why this bleeding is a painful bleeding. Okay, and that is why here cochlear uterus is there, because you can see here in the image the blood has been, you can see here in all this is that in the myometrium the blood is collected, okay, which has clotted, and this has become dark maroon or wine colored uterus. Okay, so what happens in abruptio? Mainly the placenta gets separate, the spiral arteries they bleed into the myometrium, and that is why this bleeding is a painful bleeding, and that is why this bleeding is a painful bleeding, and that is why this bleeding is a painful bleeding, and the uterus becomes tender to touch. Okay, and because now the placenta has separated, the main blood supply of the fetus has hampered, is not good. So that is why the fetal distress occurs. So this triad is particularly of abruptio placenta: abdominal pain, tender abdomen, bleeding. It can be concealed or revealed, abdominal pain. Sometimes they don't say you abdominal pain, they say tender abdomen. So it is one and the same thing, because pain is due to the blood which is going inside the myometrium. So it can be tender abdomen or abdominal pain. So bleeding, it can be concealed or revealed, and there is fetal distress. Distress, or it can also lead to IUD. So this are the three features of abruptio placenta. Once again I will tell you, first feature is abdominal pain or tender abdomen, second feature is bleeding concealed or revealed, and third feature is fetal distress or IUD. All these are due to separation of the placenta. Now this placenta has separated or not cannot be seen on ultrasound. So it is only and only it is suspicious, it can be diagnosed clinically. There is no proper investigation to diagnose this condition. No ultrasound, MRI, no condition can diagnose. So it has only and only clinical suspicion and diagnosis. Okay, so because now this clot which I told you is behind the placenta, this clot which I have drawn with red color, this clot can go into the systemic circulation and it will release thromboplastin and it can cause DIC. That is why this abruptio is very very dangerous. Okay, one thing we studied that the separation of the placenta lead to cause the blood to go into the myometrium, which caused abdominal pain or tender uterus and which caused fetal distress. Now this separated blood which is behind the placenta, it can also go into the systemic circulation and it can release thromboplastin and it can cause DIC. So that is why the treatment of abruptio placenta is immediate termination. Once you have diagnosed this condition, please immediately terminate the pregnancy. And because it is one of the obstetric condition in which the normal delivery is very easy, so always if there is no fetal distress, please prefer normal delivery. Or any other obstetric indication, then you have to prefer normal delivery over cesarean. Okay, I agree that patient can go into DIC, but normal delivery happens very easily. As we studied in preeclampsia, normal deliveries happens very easily. That is why normal delivery is preferred over cesarean. In the similar way, here in the abruptio, normal delivery occurs very easily, so we are going to prefer normal delivery over cesarean, but we have to immediately terminate. Once we have diagnosed, we have to immediately terminate the delivery. Okay. Okay, next is if any indication, obstetric indication is there, so then we can do cesarean, but abruptio placentae itself is not an indication for the cesarean. So Share and Page have given a classification. So to classify how severe the abruptio placentae is, you have just to remember the you have just to remember the name of the you have just to remember the name of the this classification, Share and Page. Okay, Share and Page. So this is a totally a dangerous condition, and only thing you have to remember is immediate termination. Okay, due to the fear that the DIC can occur to the patient. Okay, so this was about the abruptio placenta. If you want me to conclude this condition, I would like to conclude it in 3 lines. Number 1 line, in abruptio placenta there is separation of placenta, and that separation of placenta caused the blood to go into the myometrium, and which cause the abdominal pain and tender uterus, and that separation of placenta also leads to the fetal distress. Okay, the second most important thing about abruptio placenta is the blood which is behind the placenta, it can when it goes into the systemic circulation, then it can release the thromboplastin and it can cause the DIC. Okay, then it can cause the DIC. Okay, and the third thing is that which we have to remember is that we have to third thing which you have to remember is that we don't have to wait for the fetal maturity, or we don't have to wait for the blood transfusion. We have just to terminate the delivery. We have not to wait for the beta methasone 48 hours, because it is extremely dangerous condition. Okay, and cochlear uterus is found in this. Okay, Now let's discuss the second condition, placenta previa. This is a question from NEET PG 2019. So this was asked that the 38 years pregnant woman is present with recurrent vaginal bleeding. On seeing the report, placenta previa was there. Yes, placenta previa can be diagnosed on ultrasound. This type of placenta previa in images, it is type 1, 2, 3 or 4. So this is type 2 because it is because it is marginal. Uh, this is this is type 2 because it is, sorry, this is type 3. Yes, this is type 3. And this was the image which was given in the uh, FMG 22. Okay, identify the placental abnormality here. So here it is totally covering the horse, so it is type 4 or placenta previa. Type 4 or placenta, central placenta previa. Now let's see what is placenta previa. Placenta previa means that placenta is in the lower uterine segment. Placenta is in the lower uterine segment. What are the risk factor? The most common risk factor is again like abruptio. The most common risk factor is previous history of placenta previa. Okay, and second most common risk factor is any scar on the uterus. Okay, second most common risk factor is any scar on the uterus, and third risk factor is large placenta, or you can say elderly multigravidum. Okay, because in large placenta the space will be less. Okay, once again, any scar on the uterus which will not not cause placenta to grow along with the uterus, so placenta will left behind in, or placenta will get stuck at the scar only. And if there is large placenta, then as uterus is small, so placenta has to shift there itself in that space, so placenta can come low lying or in the elderly multigravidum. The recent classification of the recent classification of placenta previa is either it is low lying or it is placenta previa. Okay, either it is low lying or it is placenta previa. Low lying means it is more than 2 centimeter or from the os. All the recent exams are giving only asking this only classification. Either the placenta will be called low lying or either the placenta will be called placenta previa. Okay, okay, okay. Now the old classification says that the four type of placenta previa is there. Type 1 is the low lying placenta which is more than 2 centimeter from the os. The type 2 is marginal placenta previa, that is it is just now everything will be with respect to the os, that it is just at the margin of the os, so it is known as marginal. And type 3 is it is partially covering the os, and type 4 is it is completely covering the os. Okay, just partially means it is covering less than 50%, marginal is just 1 to 2%, complete is 100%. Okay, so now let's see our this diagram. You can see here that this is marginal, sorry, this diagram. So this is just marginal because this is os, so this is type 2. Okay, this is type 2, and these images are a bit confusive. Okay, on telegram there are much clear images. As you can see, this is low lying means it is more than 2 centimeter from the os. It is more than 2 centimeter from the os. It is marginal means just covering the os, just at the margin of the os, okay, and here it is partially covering the os, and it is here it is 100% covering, okay. 0 to 50% if it is, then it is marginal. And if it is more than 50%, it is mm, partial, and if it is 100%, then it is complete. Okay, so you have to see how much percentage it is covering. Okay, now what are the investigations? So first of all, what are the symptoms? It is the painless bleeding is a symptom, and the investigation which we have to ask is the ultrasound. On TVS ultrasound can be done, though no doubt PV is contraindicated. And how we are going to manage the patient if it is a premature, once again here in the management I want to tell you that in the management I want to tell you that it is not essentially that placenta previa, when it is written placenta previa, it means the patient is bleeding or the patient is having antepartum hemorrhage. Placenta previa means placenta is low lying, it is will be bleeding when patient bleeds. Okay, so placenta previa can bleed, so we have to see in the question that whether they are writing placenta previa is bleeding or not. So antepartum hemorrhage and placenta previa are not the one and the same thing. So placenta previa will become in antepartum hemorrhage if it bleeds. Okay, so management is that normal no that management is that in low so we have to see what type of it is in low lying and type 1 and in type 2 interior placenta we can do the normal delivery, arrest all the conditions we have to do the cesarean. And if the bleeding has happened before the 37 weeks, so here I would like to tell you that there are chances that this bleeding can stop. It is not that once bleeding has started it will not stop. So we will, if the mother vitals are normal, mother condition is normal and bleeding is not much, and fetal condition is also stable, then we can do conservative treatment which is known as Johnson and McAfee regimen, and that is to be done only and only if mother and fetal conditions are stable. If they are not stable, for example if there is fetal distress or mother vitals are deranging, if there is much high bleeding, then we are not going to wait for the then we are not going to do the conservative management, then we will do only and only the cesarean. Okay, what is Stelworthy sign? This is one name which is associated with Stelworthy sign, means type 2 posterior, type 1 type 2 posterior and type 1 posterior placenta previa, it is associated. Now it says that if head is pressed in the pelvis, in the case of type 2 posterior and type 1 posterior, then the fetal heart rate decreases. Okay, then the fetal heart rate decreases. Most dangerous type is type 2 posterior. Okay. Okay, now the last note about the tocolytics. What are the use of tocolytics? Whether it is abruptio or whether it is placenta previa. If it is bleeding, if the patient is bleeding, then we cannot give tocolytics. Tocolytics will worsen the situation. But if in the placenta previa, as I already told you, it can be also of non-bleeding type placenta previa, then we can give tocolytics if there is a patient is complaining of preterm labor pains. Okay. Now let us go to the RH negative. Here I just want to tell you in this chapter in short. Just listen to me. Then we are just covering here in the revision time one liners. RH negative and RH if the mother is RH negative and the husband is RH positive, so there are chances that baby can be RH positive, right? There are chances. So if the mother is Rh positive, then there are no chances that the baby will be Rh sorry if the mother is Rh negative and the husband is Rh positive, then there are chance that the baby can be Rh positive, right? There are 75% chance that the baby can be Rh positive. Okay, so now if the baby is positive, let's think the worst. If the baby is positive, now whenever the fetal blood will enter the maternal circulation, whenever it will enter, when the fetal blood enters the maternal circulation, now here we are talking when the positive blood will enter the negative blood of the mother. When it enters, there are some suspicious time when this fetal blood will enter. They are at the 28 weeks, or when abortion or delivery occurs, or if we do any invasive procedure like amniocentesis or chorionic villi sampling. Okay, so these are times, suspicious time when the fetal blood, the positive blood will enter the negative blood. Okay, so when this positive blood will enter the negative blood or the mother blood, so then now that mother is negative and some antigen is entering into the mother blood. So now the mother blood will make antibody against this foreign antigen. Okay, and when against this foreign antigen, or you can say against the fetal blood, now when this antibodies will be made, then now these antibodies will now enter the fetal circulation, which were formed in the mother blood against the fetal blood, now will enter the fetal circulation and it will kill the fetal blood. Okay, or you can say hemolysis will occur. Now when hemolysis will occur, then fetal anemia or hydrops fetalis can occur. Now that you understand how hydrops fetalis occur in the patient of Rh negative mother uh, whose fetus is Rh positive. Okay, because whenever the fetal blood will go into the mother will make antibodies against the fetal blood, and which will cause hemolysis or hydrops fetalis. Now we cannot stop the entry of fetal blood into maternal blood. Okay, but we can stop the mother to make antibodies. How? Oh, because, or we can, in other words, we can say, I can say that we can stop the sensitization of the mother. I can't stop the entry of the fetal blood into the mother blood, but I can stop mother to make mother red blood cells to make antibodies. How I can stop is that also I will tell you. I can stop that if I will give antibodies is out from outside, NTD, if I will give from outside, then the maternal red blood cells, they will not get sensitized and the fetal RBC will get killed, right? So now the bulk of antibodies which were transferring from going into the fetal blood, now they will not go and hemolysis will not occur. Only that blood which has entered into the mother blood, there only hemolysis will occur. Okay, and that is what we do, and that is what is the treatment of Rh negative incompatibility. We give anti-D to the mother whenever those suspicious fetal to mother transfusion is there. Okay, and that I told you that periods are 28 weeks after abortion, after delivery, or after any invasive procedure. These four things you have to remember: after abortion, after delivery, after at 28 weeks, and and after during the invasive procedure, amniocentesis or chorionic villi sampling. So now we have to check before giving this antibody. We have to check that whether there was prior sensitization of maternal RBCs to make antibodies or not. That we check by indirect Coombs test antenatally in the mother's blood and direct Coombs test post delivery in the fetal blood. ओके, बिकॉज अब तो फीटस बाहर आ गया तो हम फीटस के ब्लड में डायरेक्ट भी चेक कर लेंगे. सो हाउ वी चेक दैट मदर वॉज मदर मेकिंग द एंटीबॉडीज प्रायरली और नॉट, दैट वी चेक बाय डूइंग indirect Coombs test antenatally and direct Coombs test post delivery. Okay, now if these tests are negative, it means that mother was not sensitized, then only we are going to give NTD at that susceptible time. What are all the time in which we will do the NTD test is, oh sorry, indirect Coombs test? What are all the time? ठीक है, one is that we will do the indirect Coombs test at first visit, and second is at 28th visit, and third is direct Coombs test after the delivery. Okay, so we have to check that it is sensitization has occurred or not. We will check at first visit by doing indirect Coombs test, second at 28 weeks, and third is at after delivery by direct Coombs test. Okay, now the dose of NTD which we give to the mother is 300 mics IM after delivery. Okay, the dose of antibody which we give to the mother is 300 mics. Question has come only once in FMG exam was on this dose. ठीक है, 300 mics after IM after delivery if the fetal blood group is positive and direct Coombs test is negative. Dose of antibody NTD after abortion or after any invasive procedure before 12 week, is 50 microgram IM. Okay, so these are the two doses. Now here I would like to tell you what is Clahor-Betke test and what is APT test difference. See, usually we assume that 15 ml of fetal RBCs have gone, and we give not more than 15 ml of fetal RBCs and gone, and we give 300 mics of NTD, because this 300 mics of NTD will neutralize 15 ml of fetal red blood cells. But there are some chances when more blood can also go. For example, if there is massive antepartum hemorrhage, or if there is any other if there is lot of bleeding in if there is lot of bleeding in chorionic villi sampling or other things, then there are chances that more than 15 ml of fetal red blood cells they have gone into the mother blood. Now we have to calculate how much they have gone. So quantifying test, okay, or where we calculate fetal red blood cell volume. So please mind, it is RBC. Whenever they tell you that we have to differentiate between maternal RBC, red blood cell, and fetal red blood cell, when we are differentiating red blood cells or we are quantifying how much blood has gone, quantity measure कर रहे हैं, then it will be done by Clahor-Betke test. Just when we are qualitatively doing, or when we are differentiating mother blood or fetal blood, qualitative blood, I am again and talking blood. In Clahor-Betke it was red blood cells, whether their cells are of mother or fetus, or whether how much quantity, that is with Clahor-Betke test. And when we have to see whether this blood is mother or fetus, whether we have to do quality, whether the blood is fetus or mother, or we have to not differentiated cell word I am not using, then it is APT test or single alkylate denaturation test. Okay, Okay, so this test is usually done in the vasa previa. The last slide is about the fetal hemolysis. Is that now when fetal hemolysis starts occurring, as you know, it occurs when antibodies they kill the fetal red blood cells, NTD they kill the fetal red blood cell. How much severe is the fetal anemia? First, that is calculated by middle cerebral artery Doppler. More if it is more than 1.5 MOM, then it is severe, and then we have to give intrauterine in blood transfusion. So how we are going to calculate how much hemolysis has occurred or not? So these days it is done by fetal MCA Doppler. So fetal MCA Doppler indicates fetal anemia, and if it is more than 1.5 MOM, then it means it is a very severe fetal anemia, and we have to give intrauterine blood transfusion. And traditionally this amnios traditionally for doing we were taking the amniotic fluid by amniocentesis, and then we were plotting the graph on the Lilly's graph, and then we were deciding how much fetal anemia was there. So nowadays it is not done like that way. Nowadays we are doing it by MCA, fetal MCA, middle cerebral artery Doppler. Traditionally we would take out the amniotic fluid, and then the amniotic fluid optical density we were plotting on Lilly graph, and then were finding how much severe anemia is there. But this is done today. So this was a question of NEET PG 2020, and the question of FMG was how much was the dose of NTD we give to the mother after delivery, that was 300 mics, and how we calculate the severity of fetal anemia was a NEET PG 2020 question, and that is we do it by MCA Doppler these days in modern obstetric, and if it is more than 1.5 MOM, then we give the intrauterine blood transfusion. That was all about these two very important topic. Thank you. See you soon tomorrow in the next video. Thanks a lot.